Can you see now?
Same. It's the same.
I can't figure out why is it. Still the same?
Yeah, it's still the same. I'll let you know once. Let me see.
So you are seeing black bars on the sides, but you can see a full slide.
Have you clicked slideshow? Because on your
I
screen
have.
I can see. Take your mouse to slideshow.
No, I have done that, ma'am. Slideshow. You can see my arrow on the slideshow mouse.
No, and then slideshow. See, ऊपर में file is highlighted. I don't think you've clicked slideshow. As I can see on your screen, वहाँ पे तो file highlighted होके हुआ.
Slideshow.
Go right. अब करो. From beginning. अब नीचे आ जाइए. From beginning.
Yeah. अभी भी नहीं आ रहा.
Next row. No. Then you have to go to the next row. Right, the left hand, extreme left hand slide from beginning. Next row. Yeah. Slideshow में आ गए ना. Then फिर यहाँ पे नहीं. Yeah. So from beginning, just send your mouse from the beginning. From beginning. ये from beginning पे click कीजिए. From beginning click कीजिए. Click on from beginning.
Yeah.
Click.
Yeah, I've clicked now.
अभी तक.
You still can't see it?
No.
Gosh.
Is there something wrong with your mouse?
No, I can see on my screen everything fine.
Okay,
so,
okay, I understand.
From beginning, I can see on my screen that there's just the full slide.
Yeah, I can see also. Hi, Sanjay.
Oh, hello. Hi, Dr. Nandita. How are you?
Good. I can also see the slide.
अच्छा, आपको पूरी slide दिख रही है?
मतलब go to the slide show.
No, that's the problem I've been trying for the last few minutes.
You're not on slide show, Sanjay.
हाँ.
Slide show पे चले जाओ तो ठीक हो जाएगा ना?
नहीं, ये स्लाइड शो क्लिक किया मैडम मैंने. नीचे वाला जो माउस है ना, नीचे जो आइकॉन है स्लाइड शो वाला.
हाँ, वो किया है.
हाँ, वो क्लिक किया. मेरे स्क्रीन पे पूरा स्लाइड आ रहा है.
अच्छा, नहीं हमारे पे नहीं पूरा आ रहा.
अच्छा सुनिए ना, ये दाहिना तरफ यूज प्रेजेंटर व्यू है डॉक्टर जगाई. राइट ऑन दैट लो. दाहिना तरफ देखिए तो यूज प्रेजेंटर व्यू. दैट पैनल जहाँ पे स्लाइड शो हम बिगिनिंग वगैरह है.
नहीं, जैसे जहाँ पे यू आर प्रेजेंटिंग है उसको क्लिक किया, उसमें कुछ नहीं है. मीटिंग डिटेल्स.
आपका स्लाइड भी चला गया.
नहीं, क्योंकि अभी
I can't say anything.
Oh dear.
But I think we can still do with it.
Dr. Jogai, just you go slideshow, just panel below slideshow, go to the extreme right. There's resolution show on. उसके नीचे है use presenter view. Can you see it? Use presenter.
फिर से बताइए कहाँ पे ऊपर.
नहीं, on that same नहीं, or go right.
Use presenter view या.
हाँ जी.
या.
अब देखिए क्या होता है.
नहीं, यूज प्रेजेंटर व्यू मैंने क्लिक किया मैडम, और उसके बाद मैं स्लाइड शो वाला आइकॉन क्लिक कर रहा हूँ. अब
अच्छा, अब देखिए.
अब तो कुछ अलग सा आ गया है.
अब क्या हो गया?
अब तो काफी सारे.
ओ डियर.
नहीं, I'll tell you, ये जो अभी दिख रहा है ना, जैसे दिख रहा है, ये ठीक है. इससे हम लोग कंटिन्यू कर सकते हैं. मतलब समझ में आ रहा है. ऐसा इतना छोटा भी नहीं है कि समझ में नहीं आ रहा है. परफेक्टली फाइन है. आप यहीं से स्टार्ट कर सकते हैं, है कि नहीं? डॉक्टर जुगैर, ये एकदम सही है. इससे चल सकता है.
अभी जैसा दिख रहा है वैसे.
हाँ, एकदम परफेक्टली फाइन है. कोई मसला नहीं है. यही से आप शुरू करते हैं. एक काम करते हैं, आप स्टॉप पर.
आई कांट सी दैट डॉक्टर जुगाई. अब तो लग रहा है कि स्लाइड देयर आर गैप्स ऑन द साइड, बट दैट पैनल हैज गॉन. सो दिस इज प्रिज्यूम्ड द स्लाइड शो ही आ रहा है.
आप एक काम करिए, आप जस्ट स्टॉप प्रेजेंटिंग. एक बार जस्ट स्टॉप प्रेजेंटिंग.
1 second.
Just stop presenting, please.
Stop
Go to the
sharing,
next
yeah?
slide.
Stop sharing, yeah.
I'm stopping now.
Yeah, fine. Let me share. And we'll start from there. Fine. कोई मसला नहीं है, हो जाएगा sort out. वो एकदम ठीक
नहीं
है.
नहीं,
Thank you.
I think it was rectified because वो बाएं तरफ वो पैनल नहीं आ रहा था.
हाँ, वो हो जाएगा ठीक. तो कोई मसला नहीं है. So we'll start. Dr. Shravasti Roy, you're there? Ready?
Yes, I'm here.
Yeah, fine. Then let's start.
So,
Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 12G, which is respiratory pathology. We are streaming live from UHS Southampton, UK via Kolkata. And the topic of the day is very interesting, and we have two very eminent people there to handle the show. First, let me introduce the moderator, and she will take it up and introduce the speaker. The moderator is a very famous pathologist in the eastern part of India, Dr. Shravasti Roy. She is an MD of pathology from University College of Medicine, Kolkata, a consultant pathologist in the famous Saroj Gupta Cancer Center and Research Institute, Kolkata, the president of the Calcutta Association of Practicing Pathologists, a very eminent pathologist handling oncopathology and especially respiratory pathology. So who better than Dr. Shravasti Roy to handle the show? Dr. Roy, please take over and please introduce Dr. Sanjay Jogai, and from there we will take it up.
Okay, where am I now? Can I be seen? Okay.
Yeah, you can be seen on the full screen. Yeah, please go ahead.
Then I can't see myself. I can be seen, right?
Yeah, I can see you.
Okay, where am I? Can everybody see me? Dr. Roy, can you see me?
Yes, please go ahead.
Okay. So, good evening, everybody, and actually good afternoon, Dr. Jogai, all the way in Southampton. First of all, thank you, Dr. Nadeem. Thank you, Dr. Nadeem, for the very effusive and exaggerated introduction, and for allowing me to moderate this session. Today's session is by Dr. Sanjay Jogai. He did his MD from PGI Chandigarh, followed by his FRCPath, and is now the consultant histopathologist, University Hospital Southampton, NHS, United Kingdom. He has a lot of experience, and his main interests are thoracic, lymph node, head and neck, and autopsy pathology. Today he will speak on neoplastic pleuro-pulmonary lesions, which are very important now with the increasing incidence all over the world and in India. And of course, the added for all of us, the added responsibility and difficulties, because we get small biopsies and we have to report them accurately, and again take the headache of keeping tissues, preserving enough tissue for all the ancillary techniques. So Dr. Jogai, we are really looking forward to getting all the practical solutions and all the details of all the lesions and your experiences. So over to you, Dr. Jogai.
Thank you very much, Dr. Roy, for the kind introduction. Thank you very much, Dr. Nadeem, for inviting me to present cases on this forum. It is a pleasure and privilege. And like the last time during interstitial lung disease meeting, I would first of all say a huge thank you to all my teachers, my seniors, my batchmates, as well as my juniors in PGI Chandigarh. They have played a huge role in where I am today. With that, I'll start my talk. So the outline of my talk is basically it's a case-based discussion. I'm not going to discuss any theoretical aspects at all. These are all real-life examples of different types of cases over last several years. I'll focus on morphology, role of immunostore chemistry in difficult cases. Although Dr. Roy mentioned about the concept and the difficulties of small biopsies, I'm not delving much into those because a lot of people are already covering those sort of issues. So it's mainly case-based studies. Although the topic of my talk is neoplastic, I have cheekily included some non-neoplastic conditions because they are basically within the differential diagnosis spectrum. Some of the cases that you are going to be seeing today have previously been presented at national and international pulmonary pathology meetings. So they may be a bit longish because they have been case presentations, and I've tried to sort of make a sort of synopsis of those cases. So starting with the first case, this was a 72-year-old male who had a right lower lobectomy for a 55 millimeter tumor. what we are going to see is a section from the peripheral aspect of the tumor, where there was another nodule that was merging with the main tumor. And basically, this is to emphasize on the morphological aspects of lung tumor pathology. So,
Just share your screen, please.
Share your screen, Sanjay.
oh,
Present
Hi,
now and
Nadeem.
then. Hi, Dr. Kakkar. How are you?
Good, I'm Nandita.
Yeah, I know you are Nandita.
Kakkar sounds.
Too formal, is it?
Too formal. You can call me Nandita.
Chill. Great. अभी तो पूरा आ रहा है.
अब आ रहा है?
एकदम perfectly आ रहा है. ये तो कोई
Okay,
कमाल हो
something
गया.
has happened.
चलो, let's start from there.
Chalo.
चलो, great.
Okay, so yeah, so let us stop and basically come to the case straight away. Now, some things may look very simple, and don't find me. I hope nobody finds me patronizing, but that's how morphology is. So, in a section like this, you can very clearly see the cells have a very squamoid morphology. So you have no problem. This is a squamous cell carcinoma in this field. Now, another area, and you can clearly see squamoid areas, necrosis. So no problem with the diagnosis. Quite a few pleomorphic cells as well. However, where the tumor was merging with another nodule, the morphology is completely different. You can see cells which have more sort of ovoid to slightly spindle nuclei. Let us look on a high power. You can see the chromatin pattern is completely different. They don't have that squamoid morphology at all. And in certain other areas, nucleoli start to appear, and the cells have a very vesicular pattern. And then there are still those hyperchromatic looking cells in the background. And this is another area from that tumor area where you can see mitotic figures. Now, if you look at the chromatin pattern, it's clearly very stippled. There are nucleolated cells as well. It looks more high grade compared to the squamous tumor. Now, going back on a slightly scanner view, you can clearly see squamoid areas, but there is a distinct component of tumor there. Now, this is a very interesting field where you clearly see squamous cells, but together with that, you have got these peripheral palisading by those hyperchromatic cells. And this is another beautiful focus to show those cells which have a more stippled and hyperchromatic nuclei with the squamoid component. Now, what's going on here? So we clearly have two distinct tumor pathologies or tumor morphologies within the same tumor, so much so that in some areas it's almost closely admixed with each other. Now, Immunostore Chemistry shows some interesting findings. So on the left of your field is a CK56, which clearly picks up the squamoid areas. And here you have synaptophysin clearly picking up the neuroendocrine type areas, and you can see the squamous areas clearly like ghost outlines which are negative with synaptophysin. When you do a P63, again it highlights the squamoid areas, whereas the neuroendocrine cells are completely negative or very focally positive towards the edge, probably representing squamoid differentiation. And Ki67, very high within the neuroendocrine component, whereas the squamous is very low. Now, it's a very simple case as far as morphology is concerned. Now, quite interestingly, in the lymph node, so this is the mediastinal lymph node, a reactive follicle with germinal center, and there you have got a tumor which is almost exclusive spindle cells with those neuroendocrine features. And look at that on a high power. Here the morphology is slightly changing in that the cells have more voluminous cytoplasm. The chromatin pattern is stippled, but the nucleoli are getting prominent. So clearly a high-grade neuroendocrine look. And this is interesting. So Ki67, just to show you an internal control, that's a reactive follicle there as well as there. So obviously these will contain lots of tangible body macrophages. You'll have a high proliferation. But look at the tumor. Very high Ki67 within the neuroendocrine component. So what this is basically a combined large cell neuroendocrine carcinoma with a component of squamous cell carcinoma. So the importance here is that Immunostore Chemistry was crucial to confirm the neuroendocrine origin of those cells. Now, with that sort of background to the slide seminar, I'll just go ahead talking a bit about the neuroendocrine tumors. Now, we all know, as far as neuroendocrine tumors in the lungs are concerned, we have typical carcinoid, atypical carcinoid, large cell neuroendocrine carcinoma, and small cell carcinoma. Now, with typical carcinoid and atypical carcinoid, morphology is not too distinct in the sense that they still show Zell-Bolin pattern or nesting or organoid appearance. It is the mitotic count and the presence or absence of necrosis. So for typical carcinoid, you tend to have less than 2 mitotic figures per 10 half-hour fields. You don't see any necrosis. With atypical, the mitotic count is between 2 to 10, and you can get necrosis. Now, this necrosis is very important in atypical carcinoids in the sense you don't always see it as large areas of geographic necrosis the way you see it in large cell neuroendocrine carcinoma. It's usually punctate. You might have to hunt. So careful sampling of the tumor is very important. Now, this is from a few weeks ago, a tumor which is endobronchial. As you can see, it's compressing the bronchus, and it has a very organoid pattern. When you go on a high power, very beautiful nests separated by those thin, almost tentacular type meshworks. And on a high power, you can see the stippled chromatin pattern, lots of cytoplasm. There are no mitotic figures, and clearly there was no necrosis. So this is an example of typical carcinoid. Day in, day out, you'll make a diagnosis on H&E. It's good to confirm it with immunos and always do a Ki-67 just to confirm that the proliferation is low. Then we have another example, a very well-defined tumor. The background looks pretty unremarkable. And there's a lot of disturbance in the background. I don't know if somebody's microphone is on. And the morphology here is slightly different in the sense these are all very spindle cells compared to the previous example I showed you. And when you look at a high power, they still have a very stippled chromatin pattern. There is a lot of cytoplasm, and again, there are no mitotic figures and there is no necrosis. So although this has a spindle cell morphology, this is again a type of typical carcinoid. Now, moving on to another case, this shows again good going nesting pattern, but even on a scanner you can make out that there is slight variation in nuclear size and shape. And what's going on there, that's important. If we look up and close, there is clearly variation in nuclear size, and occasional cells are sort of starting to show tiny nucleoli. I can't see any mitotic figures in this field, but what's very interesting is there was just one focus where you could see this necrosis, and I'll show you on a higher power just to convince that there's clearly necrosis going on. Now, in this particular case, there were mitotic figures, 3 to 4 per 10 high power fields. There is necrosis, and nuclear pleomorphism is there as well. So this is an example of an atypical carcinoid tumor. Now, the differentiating features between the typical and atypical carcinoid so far are based on morphology only. In times to come, Ki-67 will be playing a more sort of formal role. We know that when we do a Ki-67 in typical or atypical carcinoids, it's typically very low, 1 to 2%, less than 5%. But that in itself is not able to distinguish between the two. Now, with that, we move to the third entity, which is the large cell neuroendocrine carcinoma. So the morphology is very crucial. You typically have organoid nesting, peripheral palisading. You can see rosettes, you can see trabeculae. Mitotic count is very high. So when you put a large cell neuroendocrine carcinoma under the microscope, it straight away is a very worrying looking tumor. And even on a scanner, you can see large areas of necrosis. Now, overall, large cell, the starting definition of a large cell is it's basically a non-small cell type. So it shows large cell size, low NC ratio. So you see a lot of cytoplasm. The chromatin pattern can be fine or vesicular. Nucleoli are prominent. So that's a very good clue. You are not thinking of small cell. Once you are starting to see nucleoli and abundant cytoplasm, one needs to come out of small cells completely. Immunohistochemistry is important. You need to see neuroendocrine markers. You can see markers, but it's important you don't just rely on NSC. Typical markers we tend to do, and I'm sure most of you do, are basically synaptophysin, chromogranin, CD56, and Ki67. Now, the clinical outcome is poor. It's worse than non-small cell, but better than small cell. Now, there is a lot of controversy about the management of large cell neuroendocrine carcinomas. Ultimately, it's the clinician who makes a call. If clinically the patient has got a high mediastinal volume disease, strong history of smoking, widespread sort of metastatic, almost like a small cell picture, most of our oncologists go ahead and treat them as small cell. But as a pathologist, you have to report what you see. Unfortunately, it's one of those areas where consensus is rather lacking. Now, with small cell, the cell size is small, so typically it's said up to 3 resting lymphocytes. Cytoplasm is scant. Nuclei tend to be finely granular. You rarely see nucleoli in small cell. Mitotic count is very high. You see lots of necrosis, you see lots of apoptosis going on. A good feature to remember is, you sometimes, although it said small cell, sometimes small cells can have large nuclei. But the important thing is you should not be seeing much cytoplasm or lack of cytoplasmic membranes, cell membranes. Now, what's combined LC-NEC? It's large cell neuroendocrine carcinoma with component of adenocarcinoma, squamous cell carcinoma, giant cell or spindle cell carcinoma. Most common component usually is adenocarcinoma. And if the second component is small cell, the tumor is categorized as combined small cell and large cell NEC. Now, few practical problems that we encounter on a fairly regular basis when dealing with small biopsies. So, the differential diagnosis that one comes across on a practical as a practical problem is this a small cell carcinoma or is it a lymphoma? And that's the single most important thing you have to distinguish, because both these have different management options. My own take on this is, whenever I see a small biopsy or a core biopsy which looks like small cell carcinoma, I still always confirm it on immunos, because it's one time when you don't do that, in that case we turn out to be lymphoma, and that's the last thing you want. So always a good idea to do synaptochromo, CD56 and Ki67. Now a quick word about immunos here. From time to time we will come across cases which are both synaptophysin and chromogranin negative. They show a very high Ki67. In those instances, CD56, I feel in lung pathology as far as neuroendocrine tumors are concerned, that is the single most important role area where CD56 plays a role. Because if you have got negative synaptochromo, but you've got a positive CD56 with high Ki67, you can call it a small cell carcinoma. Suppose we get these markers as negative, it's always a good idea to put an LCA, because you could be having a high-grade lymphoma which is showing a high Ki67, and you wouldn't want to miss a high-grade lymphoma compared to a small cell carcinoma because it's much better treated. Ki67 can be helpful. Typically in carcinoids it's quite low, and large cell NEC and small cell it's very high. Surgical resection, very uncommonly you would get surgical resections of small cell carcinomas, and in those the nuclei can look larger, but again one has to go back, do you have more cytoplasm? And if that is the case, if nucleoli are prominent, one should favor a LC-NEC. Every now and then we come across cases, every few months I come across cases where you see within the same section areas which look like small cell, whereas other areas looking more cells showing more cytoplasm, nucleolar prominence, and you are wondering, is this small cell, is this large cell neuroendocrine? I feel tumors don't read textbooks, as some famous pathologist said once. So within the same tumor you can see different morphological features. So a good idea there is to give a summary, and the way I express is, as a bottom line I would say high-grade neuroendocrine carcinoma, but within the free text describe that there are areas within this tumor which look like small cell. However, in other areas there are features of large cell neuroendocrine carcinoma, invariably the clinicians would be treating these cases as small cell. But as a pathologist, we are most appropriate when we can express that dilemma. Now, leaving that aside, the neuroendocrine discussion, we can move to another case. At this stage, did anyone want to say anything or wanted to share their?
I think yes, Dr. Jogai, Dr. Rajiv, before I go on to Dr. Rajiv Bansal had a question on why Ki67 is not part of the standard diagnostic panel, why it's not recommended. Am I right, Dr. Rajiv? The chat box has disappeared. But he was asking, hello?
Right.
Yeah.
He was asking why it's not part of the standard diagnostic panel.
No, absolutely.
The question is why the MIP1 is not included in as a criteria in the diagnosis for reading of the tumor.
Yeah, your point is absolutely valid, Dr. Rajiv. We also feel, I think by the time the next WHO classification is published, this will be incorporated. One of the reasons why it is not, I think in my opinion, morphologically sometimes you see a case where the features are so typical of a low-grade neuroendocrine tumor, whether it is typical or atypical carcinoid, but the proliferation is high. Now, so far the WHO has, the 2015 classification, it has still stuck to morphology, but you are absolutely right. In the coming years, we will have a classification system which will be based on Ki67. So for example, if we look at pancreatic or biliary tumors, the pancreatic nets, there the Ki67 is so crucial. So your point is valid, but I'm no authority to say, but it will come up in the system quite surely.
Okay. So
I was expecting this in 2020, the new WHO, but still they have not included in the.
Yeah, I know. I think there is something going behind the scenes. I'm not aware as well.
okay. So before you go on to the next case, I just like to share my experience with you that CD56 is really the one that doesn't ever let you down generally. So I have also found. So I've been also advocating it to all my juniors whenever they've done it. So
absolutely, Dr. Roy. Yeah. In 2013, I attended the Pulmonary Pathology Society meeting in Grenoble, and the president Elizabeth Brambilla did the main talk, and that's one take-home message I got from that talk. That if you are doubting something this small cell, don't get disappointed if the synaptone chromo is negative. That is one area where CD56 is so useful. Exactly. Even in completely crushed specimen, if you see a CD56 positive, the clinician can treat.
Yes. So if there are no more questions, please take the next case. Jogai.
Thank you. So case number 2 is a 61-year-old male who is a current smoker. This is from when the case was. There was a right upper lobe mass which was PET avid. A true cut biopsy was done which reported as a non-small cell carcinoma, and the PET staging was showed a T2N1 tumor, and the surgeon noted an enlarged lymph node within the main specimen and sent us the right upper lobectomy. So this is how the lobectomy looked. So it's almost reminiscent of the previous case to some extent. So you have areas here which are highly necrotic with slightly more cytoplasm, whereas cells here look more organoid, more sort of bluish, neuroendocrine look. We go on a high power and you have similar sort of spindly cells with stipple chromatin pattern. And there are other areas where the cytoplasm is more abundant. The cells have started becoming nucleolated. You have got good going necrosis, lot of apoptosis there, and again Immunostore Chemistry. It's so beautiful, and it's quite gratifying when you see simple techniques like P63 highlighting this squamoid component, whereas chromogranin is beautifully positive in the neuroendocrine area. Now this is Ki67. And in the neuroendocrine area, you can see strong positivity.
Sharing the screen now. Stop sharing the screen, please. Dr.
Can you see the slides?
We can't.
Am I doing something wrong?
No,
we can't
you
see your
didn't do anything.
slides. We can't see your slides.
Actually, Dr. Guha, you shared the screen suddenly, so that
Actually, yeah.
Am I okay?
Dr. Guha will have to stop sharing the screen first. Then Sanjay, you share the screen again.
Yeah, requesting everybody, please don't share your screen, because then the presenter's screen just goes away and the presenter is unable to understand whether the screen is there or not there. You
Yeah,
just
because
have to
I've got.
present now. Yeah, well, then we'll sort it out. Yeah, just
Okay.
present now and then go ahead with that. Right.
So I've clicked resume presenting.
Yeah, perfectly
Yes, fine. Now we can see it. Fine.
Yeah, absolutely
Okay.
fine now. Requesting everybody, please don't share your screen.
Okay, so I'll go back to the previous slide. So this is key 67 where I left. So in the squamoid area, the key 67 is quite low, whereas you see in the neuroendocrine, the key 67 is very high. Now, interestingly, the lymph node metastasis that I was talking about, you can see very neuroendocrine appearance to the tumor cells. So this is again another example of combined large cell neuroendocrine carcinoma with squamous cell carcinoma. So when people have a neuroendocrine component in their tumor, these patients behave worse than just normal, the common squamous cell carcinoma. Now, we slightly digress now to other territories. So this is case number 3. Ex-smoker, no asbestos exposure, 76-year-old male. He had a right lower lobe mass. They thought it was a lung primary and they did a CT core biopsy. So this is nice and simple in the sense you can see gland forming tumor, clearly an adenocarcinoma. No problem there. And that's the Immunostore Chemistry panel. I'll talk about this case in a minute, why we did what we did. So this is CK7, as you can see, nicely, strongly positive. This is TTF1. So TTF1 is negative. And this is CK20, which is negative. So essentially, we have got a core biopsy with CK7 positivity, 20, and TTF1 negative. So what could this be? It could still be a lung cancer, lung primary, because as we know, 25 to 30% of lung adenocarcinomas can be TTF1 negative. Unfortunately, we don't tend to use napsin much because there are not many fans in this part of the world. So TTF1 is our main go-to thing. So I reported it as such and left it there. Now, all our cancer cases are discussed on a weekly multidisciplinary team meeting, every single case. So we went to the MDT and I said, this looks like adenocarcinoma. It is TTF1 negative, but 7 is positive, 20 negative, so it will still fit in with lung primary. So the oncologist comes back to me and says, hang on, this patient has got history of prostate cancer. Can you do markers, please? I said, okay, it doesn't look like prostate, but we'll do. That's fine. So did PSA and PAPA, and trust me, you will hopefully, both were negative. I don't have the slides on that. So the MDT decided, okay, so this is a new primary. We know the history of prostate. Let's go ahead and do a lobectomy. So a lobectomy was done. And as you can see, it's almost, you'll be convinced that it feels as if the core biopsy would have gone somewhere here because it's the same pattern that we are seeing. So we have got an ACNR pattern adenocarcinoma, no problem there. Now, that's where the interesting bit starts because this is the only case I have seen, so I'm quite excited about it. This is a closer view and barn door adenocarcinoma consistent with lung, no problem. Now, this is a mediastinal lymph node. Now, have a look at this. The morphology is slightly different here. They are small, sort of tiny acini. I'll show you on a higher power. Look at that. So very small acini with central lumen, round nucleoli, very stippled sort of chromatin pattern, maybe tiny nucleoli. The plot thickens. So is this something else? Are there two things going on? And lo and behold, this is the prostate-specific antigen. So this is PSA on that lymph node, which is completely replaced by a prostatic adenocarcinoma. Okay? So I was quite perplexed. What's happening here? Because the lung was clearly an adenocarcinoma. So I thought, have I missed something? So I went back to the lung, took more blocks. Before that, I did a TTF1 on the lymph node. clearly negative. And when I went back to the lung, took extra block, so you have got a lung adenocarcinoma beyond doubt, but bang next to it are these different looking cells. I'll show you on a high power to convince. Look at that. So that's an acinus of a lung adenocarcinoma, and these are completely different looking cells, bang next to each other. And look at these cells. They are prominently nucleolated. This is a very high power, so they look very atypical. But otherwise, the chromatin pattern, the rounded, very sharp, sort of almost like you can draw it with a pencil, sharp outlines of the nuclear membranes. And this is a PSA on a section from the lung. And you can see that area is very nicely highlighted by PSA staining. And this is prostatic acid phosphatase because it was an unusual case. I thought I should do more. And you can see in the background, that's the lung adenocarcinoma, which is completely negative. And then, because it was becoming quite interesting, we went ahead and got a bit too crazy with taking blocks. So took 15-20 blocks from the background lung, and look at that. That's beautiful. That's within a vessel, you've got prostate adenocarcinoma. Look at that. Inside a vessel, you've got the tumor with typical morphology of a prostate adenocarcinoma. Another area showing intravascular tumor emboli. So basically what we are dealing with is a primary pulmonary adenocarcinoma, which is SNR predominant, PT2A and not based on like no lung tumor metastasis. But what interestingly this patient had was a coexistent metastatic prostatic adenocarcinoma to the lung with lymphangitis carcinomatosis type spread, and also metastasis to the mediastinal nodes. So then I dug up the hospital records, what was going on. So the gentleman had a prostatic adenocarcinoma diagnosed in 2000, which was Gleason 4+3. He had widespread metastasis both to bones, lymph nodes, as well as lung. And it was during the course of follow-up that the lung lesion was identified. And imaging-wise, they were very convinced this was a second primary. That's why they went ahead and did the biopsy and the lobectomy. And then digging up literature, before I presented it at one of the meetings in Amsterdam, I came to realize that there are quite a few case reports where you can see metastasis from other malignancies combining with lung cancer. So yeah, I think it's more of a carcinoma, but I felt it was quite interesting. I haven't seen two tumors within the same lung like that, so I thought it was a good case to share. If anybody wanted to make any comment or any questions.
Dr. Jogai, if I may ask?
Yes, please.
Yes. What is the issue with napsin A? For example, in this case, once the TTF1 was negative, and particularly when you are out to prove that there was a coexistent lung primary, we would have gone in for a napsin A. So you said people out there are not a fan of it. What is the reason?
Yes. Yeah. So your point is very valid. Some centers do have napsin. We don't have napsin within ourselves, within our department. And I mean, in so many years, we have seen that TTF1 and the clinical plus CK7 more or less clinches. I have posed these questions to people like Andrew Nicholson at Brompton, John Gosney in Liverpool, and they said the same thing. They said in most of the situations, TTF1 sorts it out. So that was the reason I was saying people are not big fans of napsin. But in America, most people or a lot of people use napsin. In this case, it wasn't difficult because there was an explanation for the lung tumor. If we had a 7 positive, 20 negative tumor, which was SNR predominant, was negative for prostate markers, so there was no doubt about that. But your point is valid. Napsin would have made a difference, but we were happy with what we had.
I suppose there are two reasons. Just to share my experience out here in Kolkata, at least, is quite a few. We get quite a few TTF1 negatives, napsin A positives. Number one. Yeah. And I guess in England the issue could be because the state is paying for the markers. So could that be an issue?
No, to be honest, we use markers very, very freely. It's just one of those antibodies which hasn't found as much favor. And when we are clinically happy that it's a lung primary, like we always put that rider that 25 to 30% of lung adenocarcinomas can be TTF1 positive. And almost always clinically it has been fine and they've gone ahead and treated.
Okay, but then there's always that risk that the clinician, particularly out here, that they're keeping, maybe they've forgotten, or the patient, you don't have the history. It could have been some other primary. So that's why I like to be extra prudent before signing it out only on the basis of CK7. I normally do an abstinence. Okay, please go on to the next case if there are no other questions.
Yeah.
Thank you.
I have a comment to make, Sanjay. This tumor in tumor metastasis, this is we had a case in which there was this person came with the meningioma, and there was when I saw the case, I didn't know the background history, and there was I said there was an RCC metastasizing into the meningioma. So
really?
There was PAX8 positive meningioma, was a nice meningioma which was EMA positive, and then later on the history that this patient had RCC 15 years ago, was operated nephrectomy. So these things do happen.
Yeah, absolutely. I completely agree, Dr. Nandita. Thanks for sharing that. That's interesting. Yeah, RCCs are very notorious. They come after 15, 20, 30 years even. Yeah. Okay. So going to the next one. Sorry. So this is case number 4. 56-year-old software engineer. In April 2008, he had sudden onset of twitching of left arm followed by tremors. He was otherwise fit and well. He was a smoker. No other significant past medical history. And this was his brain scans. Please don't ask me tricky questions. All I know is this is T1 weighted image. This is the T2 weighted image, and we can see a mass lesion. Now, clinically, they thought, could this be metastasis? Because on CT chest, there was a small nodule of uncertain significance. And they said it was too small for biopsy. And they felt it was very odd that such a tiny nodule could cause a metastasis. So they went ahead and did a frontal craniotomy with frozen section. On frozen section, this was reported as poorly differentiated malignant tumor. Not personally me, but the neopathologist said this could be a primary, this could be secondary, and they will stop. Now, this is where it became interesting. So this is a very low power view. You can see lots of necrosis with sheets of tumor cells. And this is slightly higher power, where you can see quite epithelioid looking cells with vacuolated cytoplasm possibly. And another high power, some of them are sort of multinucleate, nuclear pleomorphism is obvious, and these sort of intracytoplasmic vacuole, you may say, they are becoming a bit prominent. And in other areas, you had a slightly sort of almost chondromyxoid or myxoid background with these spindle-shaped cells, bluish material in the matrix. And this is a reticulin, quite heavy reticulin. So a huge panel of immunos were done. It was negative for EMA, 720, S100, HMB45, melan, ATTF1. The only thing it was showing positive was MNF116 and CK8. Now clearly these are epithelial markers. Now this is CK8, which is nicely positive. So what could that be? Is it a metastatic carcinoma, would we think? I'll carry on, I think, otherwise we'll be here for quite some time. So now I'm showing you some features on a high power. So this is an intracytoplasmic lumen with a red blood cell in it. A lot of epithelial morphology of the tumor cells. And this is the clincher. So this is a CD31. All those tumor cells are strongly positive. This is CD31 on a high power. And this is CD34. And key 67 is not, it is on the lower side, definitely. So patient received high dose involved field radiotherapy for a malignant, as he would receive for a malignant glial tumor. In 2008 made complete recovery, good recovery, and returned back to work. In April 2009, he started to have episodes of chest pain and dyspnea on moderate exertion. Now, what they did was, they found on imaging some pleural based nodules. So this is a low power to just show you how limited it was. There was nothing going on inside the lung. It was all pleurally based. You saw this proliferation of cells, which are not too dissimilar from the previous brain tumor. And you can see clusters and islands. And again, that blue tinged background, very epithelioid morphology, and intracytoplasmic lumen starting to appear. Again, moderately pleomorphic cells. Another view showing you a mitotic figure as well. Another view to show similar cells infiltrating into the underlying overlying fat, and a very nice view to show you a red blood cell within a lumen. And it was an odd case, so it was prudent to do all immunos, so calretenin, CK56, WT1 negative, so clearly not meso. And once again, CD31 was strongly positive. And this is CD34. For some reason, CD34 and factor VIII were both negative. This was the image from 2009 November. In 2010, unfortunately, presented with quite aggressive looking CT, and basically he was diagnosed with progressive pneumonitis. They thought, could it be infective? Could it be drug induced? The infective screen was completely negative, and he died in 2010. So what this is basically is a primary intracranial epithelioid hemangioendothelioma, which had metastasized to the right pleura. Now, quick few words. At that stage, it looked as though, oh, this is very unusual. Is this the other way around? But clearly, bulk of the disease was in the brain, and on doing literature search, clearly there were reports of primary intracranial epithelioid hemangioendothelioma with metastasis. So it's extremely rare. At that time of presentation, there were only 38 cases reported, quite a few with local invasion and recurrence, 15% having metastasis, and a mortality rate of 15% as well. That's from the lung book. Now, when it comes to, the reason I put this case was, you can see a pulmonary epithelioid hemangioendothelioma as well. Now, the way they show it on the pleura, it looks as if it could be malignant mesothelioma, because the proliferation can be on the surface. Immunohistochemistry is key. So we do all vascular markers, 31, 34, factor VIII, FLI1. Now we also have ERG, which can be used. Focal cytokeratin expression can be seen in 20 to 30% case. So that is very important to remember. Epithelial tumors in the pleura, which are showing epithelial marker positivity, if they are not malignant mesothelioma, always a good idea to do vascular markers, because you don't want to miss a malignant vascular tumor. So the common epithelial tumors are adenocarcinoma, mesothelioma, melanoma, adenomatoid tumors, pretty uncommon, synovial sarcoma, and this is a case of epithelioid hemangioendothelioma. With that, we'll move to case 5 and then probably have a bit of discussion. So 61-year-old female presented with shortness of breath. This is again from 2009. I had just become a consultant and I struggled with this case. So very sclerotic looking pleura and lots of these sort of islands of infiltrative cells. Now morphologically they don't look very atypical. They are sort of medium sized, there are not many nucleoli, very occasional mitotic figures. And I did a plethora of immunos. So all the epithelial markers were negative, mesothelioma markers were negative, melanoma was negative, neuroendocrine markers were negative, TTF1 estrogen, I haven't put here, obviously lymphoma markers were negative. And I just gave up. I thought, what is happening here? And thankfully, it's always a good idea to know people whom you can send your cases when you're starting as a consultant. Always good to have some hand-holding for difficult cases. If you're making some rare diagnosis, always a good idea. Do you want it to be supported rather than making a rare diagnosis which may not be correct? So in this particular case, it clearly shows on this slide that I haven't included any endothelial markers, and that is what I had missed. So I had done everything and I thought I can't make a diagnosis. It has to be something, but what do I do? So I sent it to Brompton, and I was kicking myself afterwards when they sent me back the CD31, which was so strongly positive. So that was a learning case for me 10-12 years ago, that if you have an epithelioid looking tumor in the pleura, and if it's negative for mesothelioma markers, always put vascular markers, because that's what it is very likely to be, or you exclude it. So this is another example of epithelioid hemangioendothelioma. Okay, so shall we carry on with a few more cases?
Yes, please.
Cases?
Yes, please. Dr.
Sure,
Nadeem?
sure.
We have time, right? Go ahead.
Okay. So this is case number 6. She was a 63-year-old lady who presented with left shoulder pain, and there was a nodule on CT scan. She was a non-smoker with no history of asbestos exposure, and they found a well-demarcated 35 millimeter nodule. Now, this is how the nodule looks. So on the left, you have reasonably normal-looking lung parenchyma, reasonably sharply bordered tumor, which looks quite blue. Very keloidal type collagen, almost osteoid-like, but definitely not osteoid. And you have these spindly cells intersecting, moderate amount of cytoplasm, intersecting whorls, and then you have occasional sort of epithelial areas as well. Look at that. So we'll come to that what it is, and there are occasional mitotic figures. Now this was the immuno. So the cells were negative for smooth muscle actin, calretinin, S100 as well as CD34. So in morphology, one would definitely consider, is this a solitary fibrous tumor because of that keloidal pattern of collagen? Is it an odd meso or a neuro or a melanoma or a smooth muscle? But everything was negative. This is MNF116. So this is one important thing. So when you see entrapped pneumocytes, it's important we are not calling this a biphasic tumor because of that, because if you do a TTF1, all that highlights. So this is clearly a non-tumorous component. These are not tumor cells. So these are entrapped pneumocytes which are showing positivity. And again, so we did some more, and EMA was strongly positive in those cells. Then we did BCL2 and CD99 as well, and both were positive. So I signed it, and Ki67 was not very high. So I signed it. It is a spindle cell sarcoma. It could be synovial sarcoma, but they are uncommon. But you would not want to make a confirmatory diagnosis till you have done cytogenetics. In this particular case, we sent it for cytogenetics, and it showed the SS18 rearrangement, and that was consistent with synovial sarcoma. So just a bit of a take-home message in the sense, if you have a spindle cell tumor which is not showing positive staining for SFT or myoid or neural derivation, and if it shows EMA expression, synovial sarcoma should be one entity to consider. So in the lung and pleura, it's relatively uncommon, maybe asymptomatic. So those are the main differential diagnoses, and most of the times, based on immunos, you can separate the two, separate these entities. And if you're considering synovial sarcoma, always a good idea to send it for cytogenetics. So useful tips, I've already actually alluded to this, and good idea to remember about EMA positivity in soft tissue tumors, synovial sarcoma, epithelioid sarcoma, myoepithelioma, and very rarely you can see it in leiomyosarcoma and angiosarcoma. But the useful thing would be that in leiomyosarcoma you will have support with smooth muscle actin desmin and HCal desmon. Case number 7. This is another interesting one. So she was a 60-year-old lady who had a left upper lobectomy. The reason she had a lobectomy was she had had a core biopsy, which was reported as something which I'll come to in a minute. On chest X-ray, she had a large mass in the mediastinum. Clinical diagnosis was, could this be thymoma? Could it be a carcinoma, thymic carcinoma, which had metastasized to the lung? So they did a left upper lobe wedge resection with station 10 lymph node taken out. Now this is a low power view. You can't see much except that there are sort of thick walled vessels and a spindle cell proliferation. And on a high power, it's interesting because you have almost intersecting fascicles of these spindle shaped cells. There is lots of cytoplasm. Some are pointed but otherwise tapered nuclei. You can't see a single mitotic figure. And this was fascinating because a section from the background lung, you saw almost like a vessel which is clogged by these tumor cells, and you have slit-like spaces of normal pneumocytes. So again, from time to time you come across this entity, and this is the immunoprofile, strongly desmin positive, asthma was positive as well, CD34 because you would want to exclude SFT, that was negative, and interestingly estrogen receptor positivity. Ki67 was low. And then if you see this entity, you have to always go back to the history. And we came to know that because she was 60 plus, she had had a hysterectomy for fibroid several years ago. But we didn't have access to the histology of that, and that was very crucial. The core biopsy was reported in Royal Marsden because at that time they didn't know, so they said either it's a leiomyoma or a well-differentiated leiomyosarcoma, and they went ahead and did a lobectomy. So basically this is a benign metastasizing leiomyoma or leiomyomatosis. We don't see many examples. I thought it was a good example to show. So these are basically incidental pulmonary nodules in previous history, in women with previous history of leiomyomas, can sometimes be found simultaneously. Usually you see them after several years of hysterectomy or myomectomy. And the important thing is to distinguish them from primary pulmonary leiomyomas. Thankfully they are rare. And it's very, very unusual to see these in a male patient. Okay, case number 8. This is completely different, and we are now sort of delving into non-neoplastic territory, and then we'll come back again. So this was a 36-year-old, previously fit and well male, and he presented with 3-month history of shortness of breath, and he had right-sided pleuritic chest pain. The bloods were normal, chest X-ray was abnormal, obviously, and he had a CTPA. And it's a very interesting CTPA. So what I would like you to concentrate is here. So that's the pulmonary artery, and you can see there is something outside the pulmonary artery. Let's take a closer look. That's the pulmonary artery and something outside, and see it's almost encasing. So what they basically saw was a circumferential soft tissue mass surrounding the right pulmonary artery. Everything else was normal. The surgeon and the radiologist were fairly convinced this was an angiosarcoma of the right pulmonary artery. And intraoperatively, everything else was fine. The only thing was the right lung, because it was so occluded, the pulmonary artery, it was just almost like non-functional. So the surgeon had no option, but he said, okay, let's do a frozen section and then we'll proceed from there. So this is the frozen section, and I still remember, this is from a few years ago, I really struggled. I said, okay, you are saying this is the pulmonary artery sarcoma. The cells look spindly, they are very crushed. I can't see much atypia, and I said, I'm not sure what is going on here, and I'll have to defer it to paraffin, but what would you do? So the surgeon said, the lung is anyway gone, which I'm sending you in a bucket, so we are going for a pneumonectomy. And you can see in the following pictures that the lung indeed was gone. This is how the lung looked. It was just like a ball of hemorrhagic, like just a balloon of blood. And I'll share with you a few more pictures. So that's the lung, and I've just sliced at the pulmonary artery, and you can see a very circumferential tumor or tumor-like growth. Look at that. So the pulmonary artery is almost like chink-like space, and the whole lung is sort of infarcted, hemorrhagic. That was the cut surface of the lung, just a bag of blood almost. And this is to start the microscopy. So that's very heavy inflammatory infiltrate, lots of lymphocytes and plasma cells. You can see the infiltrate going transmurally, and we'll come to that, we'll leave that for the time being. Lots of giant cells. Now, interestingly, some of the giant cells have chewed into the elastic fibers, lymphocytes and plasma cells, lots of plasma cells. Again, look at these giant cells on a close-up, elastic fiber ingested. And in some areas, there was a bit of sort of karyorectic debris as well. Again, quite a few giant cells. And it was extending into the sort of arteriolar area within the fatty tissue as well, the inflammatory changes. And very occasional aggregates of neutrophils. And the background lung was just very hemorrhagic and congested. Didn't see any tumor. There was no evidence of a sarcoma. So what are we dealing with? We have something. So this is interesting. So this is an Evg stain, and you can see the vessel, how the elastic lamina has been completely ripped apart. It's so fragmented. This is another focus to show a very fragmented elastic lamina. And then we did immunos as well, because there was a very heavy lymphoid component. So lots of T cells, but a lot of B cells as well. Now, because of the plasma cells, I got interested, could this be a variation, sort of a presenting form of IgG4? So this is IgG, lots of IgG positive cells. There were a few, but not that numerous. So we also sent for serum IgG4 levels, they were normal. And it was an odd case. So it was a pulmonary artery. So we also wanted to exclude syphilis. Not that I've seen an example here, but we did Treponema pallidum immunostore chemistry, that was negative. So what we are basically dealing with is large vessel vasculitis, granulomatous large vessel vasculitis. So essentially we just have two differentials, either a giant cell arteritis or a Takayasu. So then started with digging of literature. Now with giant cell arteritis typically involves the aorta or its major branches, shows a predilection for extracranial branches of carotid artery. Often, most of the times in your practice, you would see it in the temporal arteries. Typically, patients are older than 50 years, and often there is the background of polymyalgia rheumatica. Interestingly, this patient was only 36. There was no PMR, there was no other artery involvement. So this was an isolated, quite interesting. So a brief few words about Takayasu arthritis, first described by Professor Mikito Takayasu in 1908, usually seen in the second and third decade of life. You see diminished or absent pulses, vascular bruits, hypotension, retinopathy or neurological symptoms, and typically you have granulomatous inflammatory disease of the large arteries. Now usually it is aorta, but on literature review I could find that there are examples of isolated pulmonary involvement as well. So these are few papers showing those. They are reasonably, quite a few of those are old. So again, coming back to the point which I made in that epithelial hemangioendothelioma case, I hadn't seen this, and it was clearly something very unusual. So send it to another specialist in Cambridge who practices more vascular pathology than we would see, and he did a few sentences saying there was nothing against the diagnosis of Takayasu, and this was an isolated pulmonary artery involvement of Takayasu. This is another paper. So age at onset is a single most discriminating factor, and with this case, the odd thing was that it was isolated pulmonary artery involvement. It presented as a sarcoma. So the final diagnosis is Takayasu arthritis of the right pulmonary artery, and basically the whole thing had come out, and he's on regular follow-up. He has been well, and you can see the imaging clearly. All gone from there. So those are the references for that. Okay, so we'll do one more case and probably then tie up a few cases together, because that would just be sort of similar. So when I put that case for discussion, I thought, could we have something sort of similar to bring in the differential diagnosis? So this is a 48-year-old female, and she presented with cough and hemoptysis, and she had weight loss, shortness of breath, and there was a mass lesion. Now I'll show you the macro in a few seconds. It was so aggressive that on frozen, although I said, could this be vasculitis, there was no option for the surgeon but to take it out. And the reason for that was the lungs look like this. Just imagine the whole lung. It was these very very hemorrhagic looking lesion with bordering areas, quite necrotic, multiple such lesions in the background as well. This is another focus, almost demarcated areas of necrosis with central sort of falling off, blood clot. And this is microscopy. So the absolute standard teaching, when you see on a scanner a section from the lung which shows this sort of geographic areas of necrosis, which is very blue, purplish blue, there's only one diagnosis that stands out. And often on a scanner you can see these isolated giant cells. Professor Kevin Leslie from Mayo Clinic often says in his talks that the giant cells in Wegener's, or so-called Wegener's, now known as granulomatosis with polyangiitis, are very lonely. You don't see them very well from granulomas. They are isolated, they are scattered throughout. So a very good clue to the diagnosis. And then you see on a high power, lots of karyorectic debris, and look at that. The vessels completely being churned, and that's an EVG, again, rip-roaring vasculitis, complete destruction of the elastic lamina. So basically this is granulomatosis with polyangiitis. So I just wanted to tie up Takayasu with GPA just to show you a spectrum. So let's do this one as well, and then probably we can wait, because there is a link between this case and the previous one as well. So this is case number 10. This is a patient with history of rheumatoid arthritis, was on prednisolone and azathioprine, and had a lung lesion which was getting bigger and was centrally necrotic, and multiple smaller lesions were also appearing. So they thought, are these rheumatoid nodules? But hang on, there were no subcutaneous nodules at all, and they took them out. So this is a low power view, central area of possible necrosis. Now that's one of the areas to show you the vessels, and you have cells infiltrating the vessel walls. And as you look around, within that admixture of cells, you start seeing these slightly larger cells which are nucleolated, and an occasional giant cell appearing as well, polymorphic background. But what was very striking, if you see a cell like this, I mean, if there were any trainees, they would just say, oh, this is a typical Hodgkin or Reed-Sternberg cell, beautiful binucleate cell. There is a mononuclear cell, again here, one more here, and clearly an atypical lymphoid population. Now what's going on? So we do some immunohistochemistry, again another area to show you infiltration of the vessel wall, quite a few. Now here there are quite a few smaller cells as well, and the isolated larger cells, and again an EVG. The reason I'm showing you this EVG is to compare with the cases of the vasculitis. Now if you look at this EVG, the elastic lamina is largely maintained. Now this is CD20 and CD79A. All those large cells, let me show you a better area of 79A. Those large cells are picking up with CD79A and CD20. And this is CD3, which shows that this is quite a polymorphic background. So you've got a lot of reactive T cells as well. And Ki67 is picking up those large cells. And this is Eber, beautiful staining. I'll show you more examples of this condition. Every single of those large cells is Eber positive. So what we are dealing with here is basically lymphomatoid granulomatosis. So I'll finish talking about lymphomatoid granulomatosis, take a pause, and then we can probably have a few minutes to discuss. So going back, this is Dr. Avril Liebau, also known as the father of pulmonary pathology. And what I would like to bring your attention to is, look at this issue in 1972 where he described LYG, and look at the number of pages. 101 pages to describe one entity. That's how thorough things used to be, in the sense they used to describe so much morphology. And the take-home messages from his entire article was basically that LYG is an angiocentric and angiodestructive lymphoreticular, proliferative and granulomatous disease involving predominantly the lungs. The question usually raised is whether the process represents lymphoma or vagus granulomatosis. Now, fever and cough are the most common presenting complaints. You usually see bilateral chest infiltrates. Most common extrapulmonary sites are skin and nervous system, and mortality rate is very high. Now, more often than not, almost always, you will see these cases in somebody who has got a background. Now, typical cases that I see are people with rheumatoid arthritis who have been treated with methotrexate, or somebody who's got a lymphoma or a hematopoietic neoplasm. I'll show you a few examples. The other states are organ transplant recipients or immune deficiency states. Now, the WHO recommends grading of LYG. So if it's grade 3, where you see sheets of large B cells, basically that means it's diffuse large B-cell lymphoma. So as far as treatment is concerned, the oncologist will treat those cases as diffuse large B-cell lymphoma. So when you do a report of those cases, you will say lymphomatoid granulomatosis pattern consistent with diffuse large B-cell lymphoma. When it comes to grade 1, you see very few large B cells, but the overall pattern is very typical, that you see an angiocentricity and some destruction. Grade 2 is somewhere in between. The treatment of grade 2 is a bit controversial. Some, depending on the patient profile, some people will be treating them as DLBCL. Now, Eber is important. In grade 1, you typically tend to see less than 5 cells per high power field. In some cases, it may be even absent, but then you make a diagnosis with caution. Grade 2 is 5 to 20, occasionally up to 50, and grade 3 is more than 50. Some caveats. So, Eber may be negative when there are large areas of necrosis because of poor RNA preservation. But the single most important thing is, how many large B cells are you seeing? So if you see sheets of large B cells, that is what is DLBCL. Now, treatment is problematic. As I have said, grade 3 is usually treated as DLBCL, to some treat as lymphoma. Grade 1 is a bit problematic, but thankfully it is very uncommon. Now, with that, I'll show you a couple of examples. This was an autopsy case that was actually, the autopsy was done by a colleague of mine. So we have a coronial system of autopsy. So this patient had a background history of myasthenia gravis and chronic renal disease. The imaging said, could this be pneumonia? And he died before any formal investigations could be performed. Now, my colleague noted that the patient had a tracheoesophageal fistula and he had multiple lung nodules. So it wasn't clear. He thought, was this metastatic esophageal cancer? So he signed it off as that based on macroscopy and sent the preliminary cause of death to the coroner, but said, okay, I need to sample some lung tissue because we want to make sure what's going on, are we right? And lo and behold, as soon as he saw sections with a dense lymphoid proliferation, he said, Sanjay, can you handle this? Because I do GI pathology, I have no idea about lymphomas. Now I got very excited because even on a scanner you can see these very infarct-like areas and these vessels standing out. When you go up and close, look at that. That's a vessel, that's entire thickness of the vessel infiltrated by cells, which show some variation in nuclear size and shape. Lot of apoptosis. And this is CD20. And look at that. All those perivascular cells are strongly positive with CD20. And that's an EBER, which is absolute clincher. So basically, this was, if you go back to the history, this was a patient with myasthenia gravis and chronic renal disease. So that's the background here. And that led to this disease. And again, we have an example of lymphomatoid granulomatosis. Now, while I was preparing this a few weeks ago, I had this patient. This was another interesting case, so I couldn't resist putting it in the same forum. So, 55-year-old male, history of Hodgkin lymphoma, had completed treatment. On follow-up, found to have multiple lung nodules. Now, it's very unusual for Hodgkin to present as lung nodules like that, but clearly the surgeons were worried and they took it out. And lo and behold, it's almost similar to that autopsy case where you see the vessels standing out, infiltrated by something is going on. And you look up and close, look at that. Absolute angio destruction of the vessel wall by these large cells. Now, sometimes these cells, like the first case that I showed you, some of these cells may mimic Hodgkin or Reed-Sternberg cells, but the clue is that there is variation. They don't all look similar. And there is a rich background of smaller reactive T cells. And the most important thing is they are CD20 positive. A proportion of them can be CD30 positive, but 15 is negative, and that's not a pattern for Hodgkin, angiocentricity and angiodestruction. And this is CD20 beautifully highlighting all those large B cells. And I was very excited to see this EBER. We now have a new chromogen, and you can see beautifully how this vessel has been highlighted with all those EBER positive cells. So basically, we have a patient who has been treated with Hodgkin lymphoma, and post-treatment has developed this EBV positive condition known as LYG. So the differential, going back a full circle, is when you see a vasculitic involvement, when you see geographic areas of necrosis, you would think of vasculitis as well, but the single most important thing is GPA would not have any atypical lymphoid cells. And I always tell my trainees, whenever you see anything like that, common things being common, always do bug stains. ZN, PAS, Grocott, weight fight, because what you don't want to miss is a treatable infectious condition. And then you take like the support of doing ANCA and everything. So basically these three things. So Takayasu was obviously a rarity, but GPA, an example of GPA with these examples of LYG, just sort of, they are not neoplastic as such, but they present as mass lesions. So that's why I included in the talk. And I think I'll stop there for a few minutes.
Right.
Very interesting, Sanjay. Lovely.
Thank you, Dr. Narida.
Wonderful.
1 hour, 10 minutes we have been on, so I've got 1 or 2 more left.
No, go ahead. There's a comment on the YouTube by Dr. NP. He says napsin A does not add significantly to the workup of cases, especially if you use panel of markers and have clinical findings.
Yeah, I would agree with that.
Yeah, it is almost exactly the same line as you say.
Okay, so case number 13 was a 62-year-old lady, and there was a lung nodule, and they thought, is this carcinoid? This is absolutely hot case in the sense this was authorized last week. So beautiful example, but I couldn't resist sharing. So the reason I brought this case was we were talking about a type of lymphoma, and this was on the low-grade spectrum. I thought, why not share? So a beautiful section showing a relatively sort of well-defined bluish lesion, clearly looks very lymphoid, background looks normal, and you can imagine that imaging-wise this could easily be carcinoid. And nice lymphoid aggregates. And how do the lymphocytes look like? So they are relatively monomorphic, very mild cytoplasmic clearing, and that's a nice area of lymphoepithelial lesion where you have the epithelium infiltrated by lymphocytes. And this was quite nice because this is an area where you can see lots of plasma cells. So plasmacytic differentiation. And the reason I clicked this picture was to show you this Ducher body, which is an intranuclear inclusion of immunoglobulins. And then went ahead and did immunohistochemical stains. This is a low power view of CD20, quite nicely, strongly positive. And this is CD10. The reason I'm putting CD10 here is to show that this is CD10 negative, because the differential we will have in this entity is a follicular lymphoma. And what CD10 does is just very occasional residual follicles it's picking up, but the tumor cells, the neoplastic lymphoid population is clearly negative. And this is CD21. This is such a crucial and interesting stain for this entity. You see nice expansion of the follicular dendritic meshwork, and this is a close-up view. Look at how beautifully the small lymphocytes are almost colonizing this follicle and expanding the follicular dendritic meshwork. Very low mitotic activity. You can barely see any mitotic activity. And then this important immunohistochemical stains to confirm the diagnosis are light chains. So this is kappa. You can see beautifully highlighting lots of plasma cells, but not only that, even the lymphoid cells are kappa positive. And it's always a good idea to compare the same sort of area. That's what I tell my trainees all the time. And this is the similar area with lambda, and you can see some background staining, but all the plasma cells and lymphocytes are completely negative. So, and this is the key 67. Again, this shows that's the area which was CD10 positive. So basically a residual follicle which is showing rich component of reactive blasts which are showing high key 67. But look at the key 67 elsewhere, very low. So what we basically have is an example of extranodal marginal zone lymphoma. Now when it comes to pulmonary lymphomas, most of the times, common things being common, we see core biopsies, lots of diffuse large B-cell lymphomas. Excision specimens, we tend to see marginal zone lymphomas. Less commonly, you will see setting, which I showed you previously, LYG. But Hodgkin in the lung as such is very uncommon. Within the mediastinum, we see a lot. I'll do the mediastinal things, mediastinal entities in another, so I'll restrict it now. And that's the final case. So shall I go ahead, present this, and then we have a closing thing?
Yes, please do, Doctor.
Yeah.
Please go ahead.
So,
Please go ahead.
This is my final case. The reason I put it as a final case is just to show you how one can be misled. That's number one, based on immunohistochemistry, and how it's important to share things if you don't know the answer. How important it is to know people where you can send stuff. So this is a case I presented at the pulmonary pathology meeting in Dubrovnik 2 years ago, 2019, sorry, or 2019. So the history goes back to January 2015, when a 58-year-old male who was regularly going to the gym, quite active, started developing breathlessness and chest tightness. He had a background history of asthma as a child, was an ex-smoker, very brief asbestos exposure. Now, imaging showed reticulonodular shadowing, and HRCT showed diffuse interstitial nodular shadowing with subpleural and fissural beading, hilar and mediastinal lymph nodes. Now, before I even go further, if you have that history, there are not many things you are going to think, especially clinically and imaging wise, this was sarcoid. That's what they said. They did a cytology, which was non-diagnostic. So they went ahead and did a biopsy. Now, as a pathologist, I'm getting a biopsy which is saying query sarcoid. So I pick up the biopsy. This is how the biopsy looks like. Clearly not sarcoid at all. So you have a bit of transbronchial lung parenchyma, but that is the single most important sort of lesion. A lot of pink with some blue cells in it. What is it? Okay, so let's look it up on a high power. Not much by means of nuclear pleomorphism. I can barely see any mitotic figures. Now, occasional cells are starting to show nucleoli. So I have no idea what is going on here. So common things being common. Hang on, you said this was query sarcoid, reticulonodular shadowing, but you do your usual immunopanel. So negative stains, epithelial markers negative, chromo negative, CD56 negative, histiocyte marker negative, Ki67 was low, needless to say lymphoma and everything. It didn't look like a lymphoma at all. But what was positive was synaptophysin. I'm sure you would agree that's unequivocal synaptophysin positivity. So I said based on morphology, it looks a bit neuroendocrine, synaptophysin is positive. Is it a tiny tumourlet that they have sampled and they have not got a proper sample or what? So I went to the MGT and they said, oh, this is probably sarcoid. But I said, if you are thinking of sarcoid and this could be a tumourlet, could it be a DIPNEC, which is basically diffuse idiopathic pulmonary neuroendocrine cell hyperplasia? Now, radiologist said something is odd, but I have no idea. Why don't we send it for review? Now, we have some very famous pathologists at the Royal Brompton and very famous, world famous radiologists as well. So we said, okay, it's good to, say hands up, I don't know, nahi pata, nahi aata, kisi ko bhejo. We did that. So send it to Brompton. So the radiology review was predominantly lymphatic distribution of disease with nodular septal thickening. Histopathologist said, unlikely to be tumourlet, carcinoma or lymphoproliferative. Is this something melanocytic or mesenchymal or meningothelial nodules even? And because I had forgotten to send the block, Andrew Nicholson said, why don't you do a few more stains? So I did S100, Melan A, HMB45 negative, did more epithelial markers negative, did smooth muscle and Desmin negative, TTF1 negative, CG99 was positive, but no idea. So went back to the multidisciplinary meeting. Now some time has elapsed. Now by this time this gentleman is having enlarged nodes in the mediastinum and the CT scan is showing some bone disease as well. But he's well. He goes on a holiday. People go on a lot of holidays. Unfortunately, we can't go anywhere right now. In September 2015, he then came back with diffuse and extensive interstitial shadowing and the sclerotic bone lesions. Now, they said, oh, there are mediastinal lymph nodes. We still haven't an idea what this is. Let's take these lymph nodes out. So, I get and it happens to be my week on the rota, I get the lymph node out. I am baffled already. Oh gosh, I have not made a diagnosis. Brompton doesn't know. And now we have got a lymph node. So, completely replaced. And when you look on a high power, they are sort of ovoid nuclei with prominent nucleoli. See, like that. So clearly it is definitely more worrying, and my tumourlet was clearly out of the window by now. This is not tumourlet, and we can't explain that in the lymph node obviously. So anyway, did a full panel of Immunostore Chemistry. Summarizing it, it was only synaptophysin positive, negative for cytokeratins, mesothelioma, melanoma, germ cells, PSA, everything negative. I thought, is it an odd one? Shall we send it for FISH for synovial sarcoma? Sent that as well. Negative. Now obviously we are getting frustrated by this time, so I sent it to Marsden. The pathologist there said he did quite a few things, quite a bit of it was repeating the same thing, said difficult to interpret, clearly behaving as a malignant neoplasm, don't know the lineage, probably a metastatic carcinoma of unknown primary, and treat it as such. So the patient receives 8 cycles of palliative EOX, completes it in March 2016, has symptomatic improvement, but 8 months later presents with progressive disease. Now imaging wise they are thinking, is this post chemotherapy ILD or is it progressive disease? and they do a VATS and send it for frozen section. Again, I get it. I say it looks non-small cell and frozen. That's all I can say, nothing more. Now, I'm sorry, this is slightly out of focus, but what I'm trying to show is this is a section from the paraffin, and subpleurally I could see these sort of nodules. See those sort of areas? And this is slightly higher power. Clearly the cells are the same we saw in the mediastinal lymph node. Now, what is starting to appear is the background is slightly more sclerotic. There are some sort of slit-like spaces. And in other areas, it has got a very spindly morphology, like that. Sclerosis, spindly, what is it? And sometimes you get involved in cases and you are scratching your head, you have asked people, still not getting a diagnosis. Clearly, it is not a carcinoma. The morphology is not of a carcinoma. So, did the whole panel again. This is synaptophysin, beautifully positive. Vascular marker 34 negative, factor 8 negative, 31 a bit iffy, but maybe, not sure. So, only vimentin and synaptophysin positive, everything else negative. Now, as I emphasize, variable patterns, some spindle cells, some sclerotic stroma. Is it showing some slit-like spaces? Mitosis are not prominent, there is no necrosis. Could this be an odd vascular tumor? But then 34 and factor 8 were negative, 31 I wasn't sure, because 31 we sometimes see a bit of background. Now, by this time I had already run out of ideas, so I had sent it to Brompton, I had sent it to Marsden, so I thought, okay, thoda aur dur jate hain. So, send it to Henry Tazelar, who is in Mayo Clinic, Arizona. I had met him at a previous meeting, and several years ago I had sent him I thought, just in the off chance, what's the harm? And he does a bit of soft tissue pathology as well. Okay. So, within a few days, he writes an email. He says, extremely challenging case. And at a recent ASCAP, he had presented a case like that. And one of those cases that actually presented clinically as dip neck, which was my only saving grace, because everything else I had not got right. And he said, I'll wait for more immunos, but he would also show it to Andrew Folpe, who is again he's quite a well-known soft tissue pathologist in his place. Now, what they got was strong reactivity with ERG and FLI1. We didn't have ERG at that time, we didn't have FLI1. And variable positivity with 31 as well. And he also repeated synaptophysin, which was strongly positive. And what was this? So this is ERG, very strongly positive. This is FLI1. And just to reiterate the morphological features, you have those H&E slides, ERG and FLI1 positive. So they had just about described this entity, which is a composite hemangioendothelioma with neuroendocrine marker expression. And that is the whole pitfall of this. So in their case series, they had seen the same thing, that these were vascular tumors, but they were showing synaptophysin expression. So extraordinarily rare tumor of borderline malignancy, admixture of these three forms, and it's basically neuroendocrine marker expression rather than differentiation. And typically only synaptophysin is expressed, and they tend to behave more aggressively. So the question is, why not call them angiosarcomas? Because the morphology is not typical of angiosarcomas. You barely saw any mitosis, and the morphology was not the way we see angiosarcomas. So this was the paper that was published. They were just doing it at that time when I had sent my case, and they basically published 11 cases. Most of them were superficial, some of them were deep as well. Mitotic count, as I said, were very low, and one of the patients had died as well. So basically this is a composite hemangioendothelioma with neuroendocrine marker expression. Now follow-up, patient became very unwell. He had to be managed palliatively, and he passed a few months ago. Now that brings to the question, if we go back to the initial slides, there was bone disease. So was this actually a primary bone tumor which had metastasized to the lung? Who knows? And that is all. Thank you.
Thank you very much, Dr. Jogai. That was an excellent and very, very illuminating lecture with such wonderful cases, especially the few very rare ones. Any questions?
One question I'd like to ask is, we have been getting quite a few vascular tumors in the lung that come as I said, we get most of our cases are true-cut biopsies, and they come as FNAC anaplastic carcinoma, and well, we have got. So, what are your favorite markers in terms of which come best?
No, that's a fair point, Dr. Roy. In the more recent years, we have seen ERG is very good, but what we tend to do is, if we are thinking of a vascular marker, I tend to do all four. So factor 8, 31, 34 and ERG. So G240 is a bit promiscuous, I find, and most of the times the most problematic I find is 31, because 31 can show a bit of background staining and it is positive in other things as well. So ERG is, and the other interesting thing with ERG is, because it's the only nuclear marker of all these, it's very nicely expressed. So if ERG is positive, we are fair and sure that it is.
But you have done SLI1, which is also very promiscuous.
Yes. So
even though WHO also recommends it in the panel, but then the FLI1 is becoming increasingly positive in so many sarcomas nowadays. Even in carcinomas, we're finding them.
Yeah, that's correct.
Any other questions? Comments? So, Dr. Nadeem, shall we close now?
Thank you so much, Sanjay. Beautiful cases. Lovely.
Thank you, Dr. Nandita. Pleasure to hear you.
It was really nice to hear you today. Fantastic.
Yeah, thank you. Thank you very much. Thank you. Take care.
Thanks, Nadeem.
Thank you. Bye-bye. There was a comment by Dr. Rajiv Kaushal who said your diagnostic approach or criteria for picking IG4 related disease of small bowels.
Sorry, I didn't get the last bit. Diagnostic criteria?
An approach for picking up IG4 related disease on small biopsies.
Very tricky, Dr. Kaushal, very tricky. As we speak, I have got a case where I have got a core biopsy in somebody who's clinically showing consolidation, imaging wise, and it's full of plasma cells. Now, there are a few scattered IgG4 positive cells. I think it's more of a clinical, radiological and serological estimation as well. So if you have small biopsies, the mere presence of slightly raised IgG4 positive cells, I would not make a definitive diagnosis. Until you are seeing histological features of obliterative phlebitis, storiform fibrosis. Now, unfortunately, in small biopsies, we may not come across those features. So the cases of IgG4 where I have been able to make a more confident diagnosis are actually resection specimens, where they have come out as query carcinoid or query lymphoma, and frozen section has been inconclusive. In those cases, we see the whole gamut of inflammatory change, all three changes. But I must confess that we don't come across lots of small biopsies where we are considering IgG4. So it is a difficult one.
Right. So Dr. Shravasti Roy, last comment from your end before we close.
No, as I said, cases that particularly the last few ones were absolutely out of this world, just totally new entities, and it makes one think of some cases we may have seen earlier, and maybe we should have thought of some more. But as I said, vascular tumors we are getting, combined squamous and neuroendocrine also I have come across. But the last few ones, I'll just have to maybe, for some of our cases with, lymphocytic proliferation, like dicey ones. But then again, as I say, I wish we got more resection specimens. It's kind of tough on focus, very tough. For example, whoever commented that napsin is not necessary if you have the clinical history, that is the operative term, having the clinical history, and that's why that is the problem. So that's why, to be on safe side, if we try to, we have it, so we do it. So wonderful case. It was really a great session.
Thank you very much, Dr. Roy.
Privileged to be part of it. Thank you.
Thank you very much.
Thank you, Dr. Nadeem, for inviting me here.
Thank you so much, first Dr. Shravasti Roy, for taking out time to moderate the session. So nice of you to be here. And Dr. Sanjay Jogai, as usual, wonderful presentation. क्या बात है, मतलब excellent.
That's very kind of you.
Beautiful presentation. So, like I said last time, the calm in your teaching is the depth of your knowledge. Wonderful, brilliant classes, so well, explained, showed wonderful pictures, and along with that, the teaching part of it is so good. I think everybody will benefit for that. Thank you so much. Thank you so much, everybody, for joining in. Thank you, Sridevi, for joining in again. Thank you, Dr. Rajiv Kaushal. Dr. Rajiv Kaushal is a lung pathologist in Tata Memorial Hospital. So he is so nice of him. On the YouTube, we have Dr. Minesh Gandhi. Then we have other people there, because Dr. NP, I don't know his full name. I'm so sorry. Thank you, everybody. Thank you, Dr. Sanjay Jogai. We'll be waiting for your Mediastinal, talk. That is going
Thank
to be
you very
wonderful.
much, Dr. Nadeem.
Take care, everybody. Bye-bye. Good night for people in India. And
Good night. Good night.
rest of a good day for all of you in England there. Thank you. Bye-bye. Take care.
Thank
Bye.
you very much. Bye-bye.
God bless everybody. Thank you.
Thank you. Thank
Take
you.
care,
Thank you,
Sridevi. Bye.
Bye. Sri.
Bye. Bye. Wonderful talk,
Bye.
Sanjay.
Thank you very much, Sridevi. Nice to see you.
As usual.
Bye.
Yeah.
Bye.
Nice to see you again,
It's
Sri.
very kind of
Yeah,
you to come. Thank you.
I'm actually traveling and listening to you in the car, so I was going in and out.
Oh, are you in the car? Oh, I was wondering
Yeah.
why is it moving? Oh, take care. Thank you. Bye.
Yeah, thank you. Yeah, bye.
Bye.
Bye. Thank you, Nadeem. Bye.
Bye. Take care, Sri. Take care. Bye.